Welcome back, everyone. This is Dr. Giuliano, and now we're going to talk about panic disorder and the panic attack specifier within DSM-5. So, first, let's talk about the epidemiology behind panic disorder. And about 15% of the population will report an unexpected fearful spell at some point within their life, but really only about 7% of patients have a panic attack. And we'll talk about some of those criteria, but it is more prevalent in women than men, and the age of onset is usually a little bit earlier for men and later for women, usually in the late 30s to 40s. It's usually a chronic disorder, but symptoms can wax and wane, so it can get better and worse at various points throughout life. Panic disorder does have a significant impact on the patient's quality of life, especially if it is untreated, and it's often associated with depression, alcohol abuse, and increased usage of healthcare resources. In children, it may be under-recognized or misdiagnosed as a conduct disorder within school. The diagnostic criteria for panic disorder from the DSM-5 really talk about how panic attacks have that sudden onset of intense fear or discomfort, and it usually has at least 4 of the psychological or physical symptoms that we'll talk about on the next page. These usually peak within 10 minutes, so it happens pretty quickly. These patients will come in and they may look like they're having a heart attack, but really it's a panic attack, but their physical symptoms they may have tachycardia, they may have shortness of breath. All those things can happen. Many patients will have diminishing symptoms over the next 30 to 60 minutes. And you also have, for the other criteria for panic attacks, the individual has to have at least 2, and they have to have one of the 2 next criteria for at least a month, and that is persistent concern over the possibility of additional attacks or worry about implications of the attack. So they may start not going to work because they had their panic attack at work, and they're concerned that they could have an additional attack if they go back. And the other criteria is the change in behavior of the patient. Again, talking about that situation at the job or avoiding where that panic attack occurred. And actually, many patients will develop agoraphobia secondary to panic attacks, with agoraphobia really meaning that they're just trying to avoid areas where they couldn't escape from if they have a panic attack. So an enclosed area or a very large area that's crowded, they may be afraid of and avoid those situations. Many patients report constant or intermittent anxiety between attacks, and a lot of times it will be unexpected, but they might expect it if they're going to encounter a scenario where they've had panic attacks before. So the physical and lab testing might show an elevated heart rate on their vital signs and elevated blood pressure. Maybe they show a compensated respiratory alkalosis after a panic attack because of their breathing rate during the attack itself. So there are physical findings that we can see with these attacks. Now, the specifier, the reason why the specifier was added, the panic attack specifier, into DSM-5 was just really to say panic attacks can occur in other anxiety disorders. So panic attacks can occur with generalized anxiety disorder, and how you would say that is generalized anxiety disorder with panic attack. The diagnostic criteria is very similar to the diagnostic criteria for the panic disorder itself. And here are the psychological and physical symptoms. Remember, you have to have at least 4, and those include depersonalization, derealization. The patient might say, "I'm losing control, I'm going crazy." They may have an irrational fear of dying. Some of the physical symptoms, as you can see, these physical symptoms are going to mimic a lot of disease states that patients present with to the hospital. Abdominal distress, hot flashes, they may feel like they're choking, that rapid heart rate, paresthesia, sweating, trembling or shaking, chest pain or discomfort, dizziness or lightheadedness, hot flashes, nausea, shortness of breath, tachycardia, choking. So a lot of not fun symptoms. So our treatment goals then are really going to be eliminate these attacks. We want to decrease their avoidance that they might be displaying because they don't want another attack. And we also want to restore their work and social functioning. The long-term goal for these patients is to sustain remission. With long-term pharmacotherapy, there are studies that have shown 50% of patients have occasional panic attacks, and then still 40% will have that avoidance of the situations where they had those panic attacks prior. Most of these patients are going to continue with these medications long-term. Most patients without agoraphobic avoidance will improve with pharmacotherapy alone. So agoraphobic avoidance is a negative. It's basically going to say it's going to be harder to treat these patients. And patients with agoraphobic avoidance should be placed on both a combination of pharmacologic and non-pharmacologic therapy. So our treatment goals are in the acute phase. We want to decrease that anticipatory anxiety. We may use benzodiazepines along with an antidepressant initially. So the benzodiazepines will kick in quicker than the antidepressants. And so you want to select a drug based off the urgency. So if it's extremely urgent, you're definitely going to probably want to add a benzo for these patients. The continuation phase, we're going to maintain or improve the anti-panic response that we had during the acute phase, while also decreasing that phobic avoidance that these patients typically have. And this is going to be for around 2 to 6 months of therapy. We can adjust our drug dose, minimize side effects. If they need a little bit higher of a dose, we can do that. We may add cognitive behavioral therapy if it hasn't already been added. And then in the maintenance phase, we can work on reducing the drug dosage. It takes a while to taper these drugs off for these patients, so it takes around 4 to 6 months to slowly taper the antidepressants so they don't have withdrawal symptoms. And after 12 to 24 months of pharmacotherapy, you can consider discontinuing the antidepressants. But a large amount of these patients will require long-term therapy. For non-pharmacologic therapy, again, it's important to counsel patients to avoid things like caffeine, stimulants, alcohol, drugs of abuse. Patients should be encouraged to continue with their normal activities while making changes to reduce stress from their lifestyle. Cognitive behavioral therapy, we talked a little bit about this before. It's going to help patients focus on ways to decrease their fear and avoidance. And it can be utilized without pharmacotherapy. It does have good short-term improvement and long-term improvement, but many of these patients will require therapy to get to, or pharmacotherapy to get to that remission, which is our biggest goal for these patients. So pharmacologic therapy, panic disorder can be effectively treated with first line with our SSRIs and SNRI venlafaxine XR. Can also be treated with imipramine. Again, TCAs are going to have more side effects. Benzos in the acute phase, and there are drugs that have been shown to not be effective. Buspirone, we talked about that for the use in generalized anxiety disorder, but you should not use it for panic disorder patients. Trazodone, bupropion, and beta blockers have all shown to be ineffective. Antidepressants are considered first-line therapy, while benzos are really more of a second-line therapy, but we might need those in the acute phase. Data does suggest that a combination during the first few weeks, like we've been talking about, is effective to delay the offset and delay of the SSRI effect. So again, here's our different first-line agents, SSRIs and venlafaxine. Then our second-line agents are benzodiazepines and tricyclic antidepressants. And then our alternative, our MAOI, which is definitely going to be last line for these patients. So our tricyclic antidepressants, imipramine has been the most studied and has shown to be effective. But some of the other TCAs have also been shown to be effective. Clinical studies do suggest these agents do maintain long-term effectiveness, but it does take some time to work, and 40% of patients will experience that increased anxiety within the first 2 weeks of therapy. And if jitteriness occurs or that anxious feeling occurs, then decrease the dose initially, and then you can slowly up titrate until the patient can tolerate the dose that you have them on. But a lot of patients will experience side effects. The most common reason for self-discontinuation of therapy is actually weight gain. SSRIs, clinical studies show that it is a class effect that all SSRIs are effective for panic disorder. 60 to 80% of these patients will eventually become panic-free, so a high percentage of remission. The onset of effects are delayed for 4 weeks, and some do not respond until around 8 to 12 weeks. And again, just like with TCAs, we are going to use low initial doses to avoid the stimulatory side effects that can be seen with these agents. SNRIs have also been shown to be effective in getting remission for panic attacks. MAOIs are reserved for patients that are failing SSRIs, SNRIs, and TCAs because of the side effect profile and dietary restrictions. Having to avoid tyramine can be challenging. It is effective in 75% of patients, but only a fourth of these patients completed trials where they are initially enrolled due to side effect profile of this drug. And then benzodiazepines, these are effective for panic disorder, and we're going to actually use higher doses. And we'll see pretty good response rates with benzodiazepines, but again, remember they do have increased side effects, concerns about dependency, risk of withdrawal. The high potency are more frequently used for panic disorder. Going along with the higher dosing, we're going to use higher potency agents like alprazolam and clonazepam. The therapeutic responses usually occur within 1 to 2 weeks, and you have to be careful with patients with a history of alcohol or substance abuse because they may be more likely to abuse the benzodiazepines. Breakthrough anxiety has been reported with alprazolam at the end of the dosing interval, so what you can do is just dose it more frequently. Switch to clonazepam is the other option. And another benefit over clonazepam, or benefit over alprazolam with clonazepam, is fewer drug interaction with clonazepam. And relapse rates can be fairly high with long-term treatment. So this is our treatment algorithm for panic disorder. So let's start at the top, and we see is urgent therapy required? If yes, we will give them a benzo. If no, we can start an SSRI or venlafaxine. And then we can assess the response in 6 to 8 weeks. If they are, at any point, we're going to continue therapy for 1 to 2 years and then slowly taper off the medication. If it's not effective, we can try another SSRI or venlafaxine. If it's not effective again, another SSRI, possibly a TCA or venlafaxine. If it's still not, we could consider adding a benzodiazepine to the antidepressants with augment maybe if there's a partial response. And eventually, we could switch to phenelzine, possibly valproate if there's mood swings along with the panic disorder. And that is all for panic disorder. So next we will talk about social anxiety disorder.